All right, thank you. For those of you who are fortunate enough not to have met me yet, I'm Christopher Voscopoulos, one of the ICU doctors and pain doctors. So today's topic is interventional procedures. So I guess I'll jump off right off the bat and talk about the one that we do most commonly, right? And that's going to be what we abbreviate as a LESI. Just stands for a lumbar epidural steroid injection. So before I jump straight into like what this procedure is about, let's just take a look here at our spine. This is going to be our hip bones, our sacrum, and then we have our spine here. So in general, when we talk about spinal, back pain, if we're going to make this as simple as possible, we're going to break this down into two general areas where you can have pain. One area you can have pain is that when the nerves come out of the spine, the nerves in some way, shape, or form can be pinched. Usually when they're pinched, it's because the disc bulges and pushes backwards. And it pinches this nerve and creates what's called neurogenic inflammation. So just inflammation of any sort, that aggravates the nerve, and then you get these pain symptoms. That's like your quote-unquote sciatica. People will talk about but when people talk about sciatica, they're really kind of referring to the sciatic nerve, but it's the same process for any type of what we call radicular symptoms. Radicular just means that any nerve in the body gets pinched, usually via this process, whether it's the sciatic nerve or not, and then it gives you this pain symptom. I'll go into it a little more in depth, right? What would someone have if they had radicular pain or that colloquial sciatica? When the nerve gets pinched, they'll commonly say that they feel like they have electricity shooting down the nerve. That's what the nerves do. The nerves conduct electricity via sodium and potassium channels. So if it's going to get spontaneously activated by itself, that's what it feels like. You get this kind of jolt of electricity going down. Another thing some people say is they feel burning. So it's usually either electricity or burning are the two major symptoms. Now, the lumbar epidural steroid injection can be excellent for this. So what we do here is we go in straight to the back here and we inject our medication. It's usually a steroid of some sort. It's supposed to diffuse to these particular areas and then help reduce the inflammation and someone feels well. So now let's take maybe something a little closer here, right? So now I am not the world's greatest drawer, so bear with me here. This could get ugly real fast. But now we're going to look at this from the side. So now I'm looking at this on the side, and we're going to have the nerves come out here. They're going back. This is going to be the back of the body. This is the front. Okay, so the nerves are coming out back here, and here's your disc in front. And usually what happens is the disc now bulges backwards this way. In a lumbar epidural steroid injection, I'm coming in this way with my needle. What can sometimes happen is that I inject my medicine, and when I inject my medicine, what happens is it can't seem to get wrapped around to the front. And that's just a limitation of the technique. We usually start with the lumbar epidural steroid injection because it's simple, it's easy. I do these in like 11 seconds. Why wouldn't we do it, right? Just boom, done. However, if it's not getting to the front, we might have to adjust our technique and use a different technique. It does take more time. And that would be called a TFESI. So what a TFESI stands for is a transforaminal epidural steroid injection. So on the side of the body, we have the foraminal openings where the nerves come out. And so what we can do is we can position the patient, and we can come in from the side, and I would literally try to put my needle right here and then inject the medicine. So the point here is that I can get into the anterior space a lot easier with a transforaminal epidural steroid injection. There are more risks associated with the transforaminal epidural steroid injection. Namely is that there could be little branching arteries up here in this region, and these branching arteries could go into the spinal cord itself. And when I inject medicine, I run the risk of damaging these arteries. So how would I damage them? One, I can damage them by lacerating them with the needle. The other area that we used to be able to damage them is by injecting depo-medrol. So depo-medrol is a particulate steroid, and if you got into a blood vessel, the particles could occlude the blood vessels. So almost all of us, and if it's not all of us yet, people really should change. What we use now instead for this procedure is Decadron. Because Decadron is a liquid, non-particulate, it's safer, and you can inject in this area. You still could damage it with the needle, so there are still risks, but at least with the Decadron, you have an extra added level of safety. To make sure that we're not in a blood vessel here before we inject, the new standard is to use DSA, which stands for digital subtraction angiography. We'll ask the fluoro machines, we'll inject contrast in it, and then the fluoro machine will go off, and then we'll watch the screen and see if there are any filling defects. What you should see when you inject contrast is it should go all throughout this area, right? Because that's what contrast does. But if you inject contrast and none of it goes there, it's going somewhere and it's going to a blood vessel. And it's being carried off. So then you know I shouldn't inject there, I'm in a blood vessel, I should stop. Most of us then will just abort the procedure and say come back another day. That's actually an important note to mention about pain medicine, right? Is all of the procedures we're doing are elective. This is not like GAN taking somebody back for a mitral valve replacement that if they don't have, they're going to die. They have pain. I understand they have pain, but if I get myself into an awkward situation here, like say in a blood vessel, you can come back tomorrow. We shouldn't go ahead and inject. Why have a major complication? So that is a review of lessees, T-fesses, and then the most common type of back pain for these interventions, which is radicular pain. So before we move on, we'll just quickly review everything again, and then I'll move on to the next. So what radicular pain is, colloquially called sciatica, but all sciatica is just if any nerve has a pinch on it, then you get a pinch of the nerve and you get an electricity feeling down the leg or a burning sensation. You can go after it at first intervention with a lessee, which is the needle coming straight in the back here, very easy to do. I mean, any anesthesiologist has done a controlling of these, right? But if the limitation is that the pinch of the bulging disc could come into the back and you're impeding the anterior portion of the nerve, and with the interlaminar epidural steroid injection, you're injecting from the behind. So you might not get the medicine in front. To circumferentially get around that, you could do a T-fessy, transferrable epidural steroid injection. You put the needle in front of the nerve here and inject. The major limitation is blood vessels that are here, higher complication rate. To minimize that, use digital subtraction angiography to verify that you're not in the artery. All right, so let's move on to other types of back pain. Get rid of some of this here. Boy, I'm going to take a huge risk here, and I'm going to try drawing again. All right, so this could get ugly fast. See how this goes. So now we're looking at this from the side again. So I don't know how to draw this any other way. So when we look at from the spine, in reality, here is our spinal cord here. And for those of you who don't have the imagination that I have, I'll actually draw it out so you don't have to. Right. And what you have is you have, I'll draw it actually down. So you have these pillars come down and come up, and they encase it. These here are called facet joints. So a lamina that comes up, a lamina that comes down, and you have a facet joint here. So this is a facet joint. And you have the same thing at all levels, up and down. And then these here form another facet joint. So what happens is that in your spine, the vertebral bodies here carry about 80% of the weight of the spine, 80% of weight. And these small joints in the back here carry about 20% of the weight. So the facets carry about 20% of the weight. However, these guys are much more fragile. And so if you have degeneration of the facet joints in the back, then this is what we typically call back pain. And it's regular old osteoarthritis of the spine. So what's someone going to say about osteoarthritis of the spine? They're going to say that when they move more, it hurts, or they aggravate it. So usually what we do is we tell people, okay, since these are in the back, we say go ahead and lean back, and we call this facet loading, and it puts more pressure on the joints, and they say, that hurts more. This is not radicular pain. This is not going to go to your leg. This is going to be local. So they'll literally say, it feels like a band of pain like around my back, and they literally take their hands and they actually, it's amazing. I think they all like attended like the same like nightclub or something, or bar or church or something like that, right? They all say the same thing. It goes straight across their back, you know, and that's how, and that's pretty much about it. It's really facet loading, and they just say it goes across the back. But this is like the true back pain that people talk about. Chronic back pain, it's always there, it never goes away. So for this, what you have here is you have these little nerves. So when you have your spine here, you have little nerves that kind of wrap around, and they innervate all these joints. Actually, I should draw a different color would be. I'm starting to get into this now. Here we go. All right, so from the spinal cord, you have these little nerves. Okay? And the red is what's called medial branch nerves. Okay, but no one calls it that because it's too long, so we just call them MBBs, medial branch nerves. So our first test for these individuals is to go in with a needle and to block these nerves. They're called medial branch blocks. And if you respond to the first injection, then we say, okay, you have this entity. What is this entity called? This is called facet arthropathy in the back. So just facet joint, and then arthropathy meaning, the arthritis. So you have facet arthropathy. The definitive treatment, or more definitive treatment for this, is to go in and to burn the nerve. I'll talk about that. But most of us, we're not we don't want to do an intervention on someone and burn the nerve and find out we were wrong. And so we usually like patients to come back for a second injection, so we can do it repeated. And if they have efficacy again, then we say, okay, we feel much more confident this is really facet arthropathy. Now you can come back for burning of the nerve, which I'll talk about. There's nothing wrong with doing one block and taking someone from burning. That's actually what the literature supports. One block is enough, but I guess maybe I'm a little more conservative as time goes on. So I'll do 2 blocks and verify. So now let's say that we've done 2 medial branch blocks and you have facet arthropathy, you've done well with it. Those diagnostic injections only last maybe a day, 2 days, a week or something like that. You want like real long-term relief. So what we do then is we do RFA. And RFA stands for radio frequency ablation. So now we basically do the same procedure where we go in and I'm going to come in here with a needle and I'm going to put my needle right at that joint. When I am at that joint, what am I going to do? I need to verify that I'm there. And so what I'm going to do is I'm going to do sensory stimulation. So sensory stimulation is just putting a little electricity on and basically just aggravating the hell out of the nerve. And then when you aggravate the nerve, they say, whoa, 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 that's the spot. And they say, yeah, stop doing it. And you're like, okay, I feel really good. I'm right at the nerve, I'm there. The next thing I do before I burn it is you do what's called motor stimulation. You go ahead and you change the impulse and you do motor. And why do you do that? Because you're going to burn something right now. So if you put the motor stimulation on, they start moving their leg, I would not burn that nerve. Or you could, but that's the last procedure you're going to do for a long time. So then we would have to reposition there. Right? So we do sensory stimulation, verify that's the pain spot, and then do motor stimulation to verify that you're nowhere near the motor nerves. And then if everything's okay, you go ahead and you burn. The burnings usually last for about 2 years, 18 to 24 months. So it's good symptomatic relief. So if you are more of a holistic physician, you're trying to look at the big picture, you see why'd you get yourself in this situation? Almost everyone's overweight or something like that. So you tell them, hey, listen, you're probably having a hard time losing weight because you have chronic back pain and you're 60 pounds overweight, right? So let's make a deal. We'll burn the nerves, we'll give you relief for 18 to 24 months, but then when you're pain-free, you have to go ahead and take care of the primary problem, which is maybe weight control or something like that. So go ahead and exercise while you have that luxury. You can repeat this procedure indefinitely. The difficulty with burning is that when the nerve regrows back, it never grows back exactly the same. And so to repeat the procedure becomes much more difficult. It's pretty much just like whack-a-mole. You have no idea where the nerve's going to come back, and you're in there just trying to jam around with the nerve and the needle, and eventually you get it, but I don't want to make it sound more sophisticated than it's not. It's just like, you're just hunting and praying. Newer technology will be freezing instead of burning. Freezing is interesting. When you freeze the nerve instead of burn it, the nerve grows back just how it was before, and compared with burning. So it's a very interesting phenomenon that we don't really quite understand why that is. I don't even have a pain clinic here yet, so I can't talk about buying new equipment, but eventually I'd like to freeze instead of burn. But I'm sure we have burning equipment that's been used for time immemorial, right? All right, so this is facet arthropathy. So what we reviewed here is this. We reviewed first radicular pain, but this is different. Now this is osteoarthritis of the spine. And we reviewed here that you have 80% of the weight taken up by the vertebral bodies and 20% made up by these facet joints in the back. But the facet joints are a lot weaker. And when they deteriorate by just bringing normal wear and tear, they develop arthritis, and you can develop this syndrome, facet arthropathy. What does it feel like? They say that they feel like they just have this broad pain that goes across their back as if it's like a belt in this area. And what we usually do is say, go ahead and aggravate it a little more by leaning back, called facet loading, and they say, oh yeah, that hurts more, and that's it. To diagnose this, what we do is we go in with a needle, we stick the little needle right here by the facet joints, and then we inject some Marcaine, or something like this. And then if they say, yeah, they have no pain, we're like, this is great, we think this is what you have. I then will go in, I'll repeat the procedure to make sure that they have no pain, and then if they still have no pain after the second one, then we'll burn, and that's radiofrequency ablation, RFA. And that's it. All right. So those are some of the two most common back pain symptoms. Now let's move on to another one. All right. So another back pain symptom could be sacroiliac disease. Get my blue marker here. So now here you have your sacrum, and then here you have your ilium, and then draw both sides here. And then there's a certain area here where the two interact right here on both sides. So there's going to be an area here where you have your sacrum, and then your iliac bones, and they interact right here, a little joint. And what you could have is you could have inflammation of that joint. So that will give you sacroiliitis. Here's the problem with sacroiliitis. Sacroiliitis, when you have inflammation, if you have it bilateral on both sides, it could really mimic facet arthropathy. Because what's facet arthropathy? Facet arthropathy is osteoarthritis, is degeneration of the joints. What is this? Osteoarthritis, degeneration of the joints. They're not that far away from each other. So distinguishing between the two is a little difficult. We have a few physical exam techniques to test whether or not you have sacroiliitis. I guess maybe I can talk about them, right? But as time, I'm going to tell you the best one. You take your thumb and you jam it into the joint. And if they jump, they have sacroiliitis. If you wanted to be fancier, well, what you can do is you can have the patient lift up their leg here, and then you push back on the joint here. And you're basically doing the same thing. You're putting more pressure on the joint. They'll say, ow. Then you take the leg and you can rotate it out. And if they have pain when you're rotating out, because it's the same thing, you're putting more pressure on the joint, then you can have pain. So those are two more fancy things to do, but just I'm telling you, just kind of thumb the turn around, jam your thumb in there, they jump, you're good. So what's the diagnosis? How do you diagnose this then? Or how do you treat it for original diagnosis? You can just stick a needle straight in. So you can come in here straight with a needle in the joint, very quick procedure, and you can inject a local anesthetic and a steroid. People usually get maybe like 3 to 4 months of relief off this, which is not that bad. And people are usually happy with it. Now, what if someone gets relief off of this, but it lasts a week? Very impractical. You can't come back every week, but it's clearly helping you. Like, this is great for a week. I love it, but it's just not practical. Well, then you have another option. The other option is you can do radiofrequency ablation again. Now, radiofrequency ablation is, no pun intended because we're in that neck of the woods, a big pain in the butt. Why? It's a pain in the butt because remember that you have the sacrum and you have all these openings, right? So you have S1, S2, S3, and S4 that opens up, and they send all these nerves to the joint, and a lot of nerves. So you're like, great. So when you're up here in this neck of the woods, you just need to burn one little nerve, a medial branch nerve, and you're good. Down here, if you're going to do this, what you have to do is you have to sequence a series of probes here to pretty much burn this entire zone. There are many different technologies that will do this, so I'll save you from doing it. But it's basically the same thing. It's osteoarthritis, and the way to get around it is to burn the nerves in the back. And you could get much longer relief than 3 to 4 months with this, but it's usually done for people who just respond for a short period of time with the needle injection with local anesthetic and steroids. So sacroiliitis. Let's review this one more time. So sacroiliac, right? You have the sacrum, you have the ilium, you have this small joint here. This is an osteoarthritis phenomenon. So if you have bilateral SI joint pain, it's very similar to the facet joints. They're in the same neck of the woods. It'd be hard sometimes to distinguish between the two, because they could say they have pain in the back in that region. There are fancy diagnosis techniques. You can go ahead and have the patient lift their leg up. You can push back here to increase pressure on that joint. You can have them turn their leg out to the side. Or you can just jam your thumb into it and see if they jump. Our original test would be to go in there with a needle. Stick your needle in there. You get local anesthetic and steroid. You reduce the inflammation area. See how they do. It usually lasts 3 to 4 months. If you have an individual that only lasts like a week or something like that, not practical for a treatment, then you can come in, you can do radiofrequency ablation by targeting all of the nerves here, S1, S2, and S3, or at least part of S4. That's it. Good on this? All right. Let's keep on moving on. Where do I want to move to? Actually, what I'm going to do, and this is not fair, right? I'm going to backtrack now to a transferrable, because if I'm going to talk about everything that I'm going to do here, we could talk about something different. Okay. We could review it and come back to it. So, because when I talk about peripheral nerves, this is also good. So let's come back here to the spine and refresh our memory with the transforaminal epidural steroid injection, right? So we talked about here that if you had your vertebral bodies, and then you had your spinal cord here, you had these joints that come down. These are your facet joints. And then you had the nerves that came out. Here you had your vertebral bodies. And the vertebral bodies could pinch back and then create a problem with the nerve here by pinching up. I do have to admit, maybe it's just me and a bias because I'm egocentric, but that picture is looking a little better as time goes on.
You're delusional.
So, we talked about here how you can go in and you can put your needle in this neck of the woods and then inject, right? So, this can be hard these days to get approved by insurance, but I love doing this next procedure. So, what we can do instead is we can go in and we can stick our needle here, and because some people, like, especially like older white females, right, have a higher risk, or Japanese female may have much higher risk of osteoporosis. You have to be careful in injecting so much steroid, and steroid has its problems. So if you want a steroid-free procedure, you can go in, and when your needle is right here, what you can do instead is you can do what's called pulse radiofrequency lesioning, and you can do continuous radiofrequency lesioning. Okay, so let's go over these two, right? So pulsed. So I come in, I stick my needle here, and then what I do is I sensory test it again, and I verify. And if you have pain, and they're like, yeah, you do that again, I'm kidding. So good, we're in the right spot. And then what you do is, with a very low pulsed electricity, you induce a seizure of the nerve. I basically call this like local ECT, right? You do ECT on the brain, they get better. Here you're causing a seizure of the nerve, it gets better. You could stop there if you want and just do pulsed, and the literature will say that you get about three months of effect. It's pretty good. If you wanted to try to get 4 months of effect, what you can do is you can do continuous radiofrequency lesioning, which means that I'm going to sit there with the dial, and I'm going to turn up to how much heat can that individual tolerate. So 39 degrees, 40 degrees, 41, 42, they say that's just enough right there. And you gently apply a continuous amount of heat right there for like 90 seconds or so, and then you stop. So you get asked this commonly. So pulse, people are like, okay, you're not damaging the nerve, but are you damaging the nerve with continuous? Because you're giving a little heat and it hurts. You kind of are damaging it a little bit, but let's review like what a scar would be like. If we have our epidermis and then our dermis, right? If we just had a superficial cut and we didn't go to the dermis, that thing will heal and you'll have no scar whatsoever. If you go deeper into the dermis, then you will have a scar. Here what we're doing is we're doing like the ever so superficial kind of like injury. And then when the nerve regenerates and heals itself, you just become pain-free for a period of about 4 months or so. And it works really well. So it's pulsed and continuous radiofrequency lesion. All right. Actually, and then since we're here, we'll jump to next. So this is all, remember, for radicular pain. Okay. So let's move on. So let's say that you have radicular pain, right? And let's say you have radicular pain and you've had prior back surgery before. To go back in for another back surgery is a nightmare because you have all this scar tissue there, right? Or you had 2 back surgeries. Any surgeon will most likely say at that point in time, we're going to do you more harm than good if we go back in. Because it's like there's no guarantees what we're going to do because how you're going to heal the whole scar tissue is difficult, right? So we're doing injections and it's working out a little bit, but then as time goes on, maybe they are only getting a month of release from a TFESI. And we tried continuous and pulse radiofrequency lesion. That was going well for 4 months, and now they're only getting a month of benefit from it. So, well, what more can you do for us? Well, obviously now you need something that's continuous all the time. So what we can do instead now is spinal cord stimulation. Spinal cord stimulation. Right, now I know all these technologies sound so incredible and this, that, and the other, but unfortunately physicians aren't that smart, right? Einstein, that dude was smart. Pain docs, not so much, right? So when you were a little kid...
Put yourself down.
When you were a little kid, right, you were at the park, you know, you fell down, you scraped your knee, and it hurt, and, you know, mom or dad came over. I guess you have to be like, you know, like, politically sensitive. Mom or dad ran over to you, and they started, like, massaging your thigh, right? And they're actually doing something that really made sense. So the thigh nerves are above in your spinal cord, your knee nerves. And then what we're doing was, by stimulating the thigh nerves, it was confusing the impulses that were coming up from your knee. So the spine can only process one impulse at a time. And when there's more than one impulse, it gets confused, and it stops sending some of the pain signals from the knee. So all we're doing in spinal cord stimulation here is then I'm going to stick a little electrode into the back. So I stick a little electrode here, and I leave it in the right spot on the back in terms of, you know, wherever I want it, lumbar, thoracic, you know, cervical, and then we put some electricity. And that stimulation is just like you're having someone constantly rub right above the pain impulse, so you block the impulses that are coming to it. These are usually done for like destination therapy, right? Like you have failed back pain and we put this in and it's just the way it is. You know, you're going to have this for the rest of your life. But there are some cases to where we can do this for, say, things like, shingles, post-herpetic neuralgia. So you have post-herpetic neuralgia, if we put these in, many patients, like 80% of patients, you can take this out in 1 or 2 years and they'll be healed, or something like that. So you can use that in this particular. So spinal cord stimulation, it's a lot of fun. It's one of the better procedures that we do. So let's, now spinal cord stimulation is really good for radicular pain. But notice how it's really good because of that, this is called the gate theory of pain, if someone wanted like the exact word, gate theory of pain. But if you didn't have radicular pain, if you had facet pain, the osteoarthritis, this is not so good for facet pain. So there's another therapy that we can do instead. And this would be, I'm going to talk about it because I'm not a big fan of it for certain things. This can be a intrathecal pump. Or a colloquial called the pain pump. Can't stand that name, but all right. So now, what are we doing here? So what we're doing here with the pain pump is we're going into the spine, into the CSF, and we have this little catheter, and this little catheter is going to secrete a bunch of medications. I usually use a local anesthetic, bupivacaine. I use an opioid, usually Dilaudid. And then I use an adjunct to make both of these stronger, usually clonidine. So the thing about intrathecal medications is that they're 1,000 times stronger than if you took a pill by mouth. And so you can give someone an incredible dose or relative dose of these medications, but they're going to have no side effects from it, because by the time it gets to the systemic circulation, everything's diluted so much. So you could use this for radicular pain. I'm not a big fan of it. I think you get yourself into trouble, moving forward with it. People require constant higher dosaging of it. There really is no difference between giving someone an oral opioid, an intrathecal opioid. You get dependent to it. You need higher dosage the whole time. I'm not certain this is a great therapy. You can use this for facet pain, and this could be good there. Same thing though, using these medications chronically, not sure if it's a great idea for people, long term. And the literature out there is kind of like, we don't really kind of know. Where we would put a ton of these in here is for cancer pain. So in your end of your life, and you got a year left to, to live, you can sit there and you can be taking a ton of opioids, and when your grandkids are around you, you have no idea where you are, right? Because you're on your, 300 milligrams of Dilaudid a day. You're like either in your chair sleeping the whole time, or you're just like delusional from the side effects. And so at least what we can do for the last, year of your life that you have, or whatever it is, we can put the intrathecal pump in to where we can give you 1,000 times higher concentrations of medicines, but you will not have the side effects. So you can interact with your kids or your grandkids, or etc. So I'm hoping to do a lot of these for cancer pain. And it's really very kind of rewarding. Since we're on cancer pain and we're talking about other things that we can do, and we're here, another thing that we can do in pain medicine, it takes a little for me to work with some of the outside facilities to do this, is we can send somebody home with an epidural. So it's called an epidural portacath. So, portacaths, we're all familiar with them, right? We put a little port here, and then we, loop up the catheter into the superior vena cava, and they go home with it, right? Well, we do the same thing with an epidural. We put an epidural in, and we contract that epidural around. The only difference is we put our port down here, just to make a distinguishment between, because it's not going to have two ports. You got a port up here and a port up there, especially because we're putting these in for cancer patients. They're in a different location. And then someone can go home with this, and then with a Huber needle, they can access this and just have the epidural infusion bag run. This has a very high rate of infection. I learned this young in my career, and it's devastating infections that you can get with this, because they're meningitis and encephalitis, and they all track to the spine. It's really bad. So people really should go home on antibiotics for these, and you probably shouldn't put this in for someone if they have more than, let's say, like 6 weeks to live. So it's really someone who has like pancreatic cancer or something really nasty where they have a short time to live, and they require high amounts of opioids, but they can't enjoy the time that they have left, maybe 8 weeks or so. So you put this in instead, you can send them home with the epidural, and they're much happier. So this is end of life care. All right, so the neck, right? You guys have all seen us do our lumbar epidural, and you probably have seen most of it do it with a loss of resistance technique. So we take a loss of resistance syringe, and what happens is when we're going through the back, we go through the skin, we go through what's called the inner spinous ligament, we get to the ligamentum flavum, and then all of a sudden we get into the epidural space, and there's no resistance whatsoever, and like the loss of resistance syringe just injects straight in. So it's just so much quicker to do that. But in the lumbar spine, the epidural space is like, on average, like 5 centimeters or so. It's anywhere maybe from like 3 centimeters, rarely, more like 4 millimeters, 4 millimeters to maybe as much as 8 millimeters in some people. So you get a lot of room, relatively speaking, to do that. When you're going to do a cervical procedure, that epidural space can be 1 to 2 millimeters big. So ramming your syringe in there and doing your loss of resistance technique, some people do it, God bless them. I was a cowboy too when I was younger, and then you just get a few complications, right? You quickly change your ways. So how do we end up doing, or how do I end up doing it? I guess most pain physicians will migrate to this, the epidural in the neck instead. So let's draw. So here you go. You have your vertebral body. It's going to be a leap of faith right here, right? Let's see how well we do this. So here, so far so good. You have your spinous process. Sorry, I can't spell work. I mean, that was not a requirement from medical school. Then you have this ligament right here. So this first ligament that I'm drawing right here is what's called your interspinous ligament. Interspinous ligament. And then what happens is your interspinous ligament, then right about here is, actually, sorry, I feel like this a little better. I'm trying, guys. As you, really, this is not my, all right, so interspinous ligament, okay, here is going to be a different color. Here is going to be your spinal cord. Wait, spinal cord here, spinal cord. Okay. And then as you get close to your spinal cord, right here, there's going to be a large structure. And that large ligament right here is going to be your ligamentum flavum. And then once you pop right through the ligamentum flavum, this, I'll just poke it out in blue. This little space right here, and I really made it more difficult for you by having okay. This little polka dot right here is your epidural space. Okay, so it's a small little thing. So what we can do instead of doing the loss of resistance technique, when we just go straight in and inject, we can put our needle in. So here's our needle. And what we do is at the end of the needle, we put a little drop of fluid. Now this is pretty cool. So when you put your little drop of fluid there, what you're doing, and you'll see us, right? So it's like really kind of, we're going like millimeter by millimeter. We're all freaking out every time we do it, right? Because like you're in the neck and everything, you got a needle, you know. So you're going millimeter by millimeter, and you're looking at that little drop, and then eventually, once you get into the space, all of a sudden the drop just gets sucked right in. Because it's a negative space. That's why we do loss resistance, go straight in. So it's called the hanging drop technique, and it goes straight in. The easiest way to do this procedure is with someone who is sitting. So they sit and they lean over something like this, and then the C-arm comes and goes over their head like this instead, and then you inject. The reason why I mention it is because, especially from the nursing standpoint, we do this because we're like self-centered people, right? It's a lot easier for us. It's a lot harder for the nurses because you have a higher complication here of people passing out. So whenever you put a needle in the neck, they could get vasovagal. So this is one procedure to where you kind of need to watch them, they need to be monitored. You need to have an IV because you might need to immediately push some epinephrine, some atropine right away because it could break vagal down. I probably have someone, vagal down once a month, with this. So it's not uncommon at all, but it's important. So that's just, it's the same thing you're doing in the lumbar spine, you're just doing it a little bit differently in the neck. We even do the transferrable technique in the neck, and that's just a little more complicated, but same concept that we do here. All right. Let me go back down to the lumbar spine here. And I think I might just show you this last one. I think I made it here. There's a lot more stuff, but I'm just going to give you the bread and butter here. So now what you could have is you could have your lumbar spine here. These are your vertebral bodies. And then what you have is you have your discs. Now your discs could get infected, they could bulge, and that's going to be disc-related pain. So how will disc-related pain pop up? Well, if you have disease of your disc, that pain is there all the time. Because there's no position that you could find to get into. They'll take your pain away. So they'll literally, I'm not really quite sure if the camera can see me or not, but here, I'll try it possible. So they'll literally be sitting and they'll be talking to, and they'll be like, my back hurts, and can you find something? No, and they're just constantly fidgeting in front of you. If you stand up, is it better? No. If you sit down, is it better? No. They're just constantly moving, and it's like at the end of the conference, like, okay, can we stop now? Because it's like you just get dizzy watching them. So that's disc-related pain. So usually what a surgeon will want to do is go in and do a discectomy. So they take that disc out, either replace it with an artificial disc, or just fuse the segments together so there is no disc there. However, we might not know what level the pain is at. And so what we can do is we can do discography. So all discography is we go in and we stick a needle into the discs, and then we inject some contrast. That's all we do. How do you know that you got it? Trust me, you know. You only need to do one of these with me. If you get into a disc and you inject contrast and that disc is healthy, they're not going to say anything. Okay, you know, it's fine. If you get into a disc that has discogenic pain, that person will like attempt to jump off the table. So it's really obvious. Now, some people don't like doing discography, and I'm not a big fan of it either. And I'll only do it if a surgeon sincerely says, hey, listen, I want to go in, I want to help this guy, but I'm really not sure what the level is. And the reason is because when you stick a needle into these discs, you could damage the discs. So you shouldn't be doing this willy-nilly for diagnostic purposes. You really only should be doing it if a surgeon sincerely wants a little help with mapping and they're not sure what level to go at. And that's it. Those are pretty much the major spinal procedures that at least I'll start doing